Non-medical prescribing, Joanne Rymell, student number b8009248. So in this presentation, I aim to discuss the, I aim to introduce the patient, review their medical history and clinical presentation. I will look at the pharmacokinetics and the pharmacodynamics in relation to the medication I am hoping to prescribe. I will look at the ethics of prescribing practice and implementation. I will also review my professional responsibilities during consultation. I will discuss the key issues of non-medical prescribing and continued professional development. And at the end of this presentation, there's a list of my reference sources. The initial consultation involves the patient who was a 30-year-old female who presented for consultation in February 2020 in my private aesthetic clinic with a view to obtaining wrinkle relaxation treatment. She believed that she was beginning to see the emergence of crow's feet and frown lines. The lady had done her research and she articulated to me that her reading had enforced the belief that prevention was better than cure when it comes to the aging process, and she subsequently was presenting for treatment at this time. Her previous medical history. On taking a medical history, it was established that the lady suffered with gestational diabetes during her only pregnancy to date. This was now resolved. She's 18 months postpartum. She is not breastfeeding and she had never received wrinkle relaxation treatment before, had no known allergies, takes no other medications and had no remarkable medical history of note and was generally fit and well. Clinical examination identified age-related lines that were evident bilaterally on the forehead as well as the crow's feet lines and wrinkles around the eyes. Also of clinical note was a very dry erythematous area on the left side extending from the medial cheek up to the temporal area. The skin lesion had the typical characteristics of atopic eczema. On further discussion during diagnosis with the client about this dry patch, she acknowledged that she had suffered extensively with eczema as a child. It had largely subsided with the exception of the occasional flare-up on her face and hands, which always seemed to coincide with the winter months and cold weather. I was confident at this point to make the diagnosis of eczema, and my DMP colleague also agreed with this diagnosis. The treatment plan. I discussed my findings and diagnosis at this point with my client. She was already aware of the visible patch of eczema and was happy with the diagnosis. I informed her that my first responsibility is to treat the eczema before we can address the issue of the wrinkle relaxation treatment with botulinum toxins, which was the reason for her appointment. I advised her that an emollient would be required to treat the eczema, and I will get her back in for review for a follow-up appointment in 2 to 3 weeks. At this point, if the problem on the skin had resolved, I would be happy to treat her with wrinkle relaxation therapy using Azolo 125 Spearwood units, which is a botulinum toxin type A. The client fully understood and concurred with this treatment plan. With the pharmacokinetics and pharmacodynamics. Botulinum toxin type A is a neurotoxic protein produced by bacterium, Clostridium botulinum, and other related species. It essentially prevents the release of acetylcholine and subsequently affects muscle relaxation. It is mixed with bacteriostatic saline in order to create a neutral pH at the site of injection, therefore allowing non-toxic components to rapidly separate from the neurotoxic part of the molecule. The neurotoxin molecule then spreads away from the injection site, which can obviously cause side effects if any non-targeted structures are reached, for example in the case of a botulinum toxin-induced ptosis. Although intradermal injection carries more risk of this type of occurrence compared to subcutaneous or intramuscular injection. The primary mechanism for absorption is binding and transport across epithelial cells. Toxin that enters the body undergoes a distribution phase, which is quite short, and an elimination phase, which is comparatively long. During the distribution phase, botulinum toxin migrates to the perineuronal microcompartment in the vicinity of the vulnerable cells, which has cholinergic nerve endings. When the toxin moves from the cell membrane to the cell interior, it undergoes programmed death. Botulinum toxin type A exerts high tropism for neurons based on its specific binding site on neuronal terminals within the affected area. The high specificity of binding is due to a high affinity interaction of heavy chain with its neuronal binding state. Botulinum toxin type A has an outstanding potency following only one treatment due to different toxin protein subunits, which mediates its high affinity recognition of the neuronal targets and its intracellular enzymatic activity that targets the synaptosomal associated protein 25. The most important factor affecting the longevity of toxin action is the ability of the botulinum toxin type A proteins to avoid cellular degradation mechanisms and survive in cell plasma for long periods of time. Relatively little is known about the life cycle of botulinum toxin type A. A systemic metabolism and elimination is thought to be via the liver. Ethics of prescribing practice inform consent. As a nurse prescriber, I must act in accordance with the Code of Professional Standards of Practice and Behaviour for nurses and midwives. I therefore made it clear to the client that prescribing activity cannot be undertaken in isolation. I am obligated to inform, where relevant, anyone else who may be able to prescribe for the client of my actions in order to avoid prescribing errors, although this is not particularly relevant in this specific instance. I also inform the client of why the proposed treatment is being recommended, the expectation of the treatment, and any potential side effects of using both emollients and botulinum toxin type A. A follow-up appointment was agreed with the client and clear notes was made of the client's information, medical history, allergies and treatment plan. Relationship to client. I had never met the client previously. She was of no relation to me and was not known by myself or any of my close friends and family, so was completely within the scope of ethical prescribing practice. Acting in the client's best interest ahead of the prescriber's advantage. My actions in respect to the client's treatment plan were completely aligned with this principle. By addressing the eczema ahead of any other treatment, I was serving the client's best interest to promote their health and well-being. Professional responsibility and accountability. Records of prescribing. I made concise and coherent written notes of the consultation and my prescribing practice that can easily be reviewed and understood if necessary at a later date by myself or any other medical professional. Leadership skills and relationship to the public health requirements in prescribing practice. I had an in-depth conversation with the client about my responsibility to promote health and well-being ahead of a secondary elective treatment. In this case, that meant needing to treat the eczema first and foremost ahead of providing the elective procedure she originally booked the consultation for. The client was able to fully comprehend the reasoning behind this decision and was perfectly happy with my proposed treatment plan in this specific case. relationship of prescriber to pharmacist and potential for drug misuse. After informing the client of the diagnosis, I was able to advise her that an emollient cream would be required to treat the eczema. I suggested the use of Diprobase after checking the Sheffield Clinical Commissioning Group's formulary, which listed Diprobase as first line, but suggested that this could further be discussed with the pharmacist, as these are available over the counter and the pharmacist can show the client all appropriate options which are available and currently in stock. In relation to the wrinkle relaxing treatment with botulinum type A, I advised the client that once the time was right following the successful treatment of the eczema lesion, I would be happy to prescribe 125 spaywood units of azole botulinum toxin type A, which I would source directly from the aesthetic pharmacist, with whom I maintain a close professional relationship, therefore negating any potential for drug misuse of a controlled substance. Key issues of non-medical prescribing and continued professional development. Continuing professional development for non-medical prescribers is recognised as being pivotal in maintaining up-to-date knowledge and skills influencing prescribing competence. Clinical supervision is also an essential element of the clinical governance framework for non-medical prescribing. Responsibility for continued professional development. As a non-medical prescriber, I am responsible for my own ongoing continual professional development portfolio and professional portfolio, keeping up to date with clinical evidence and best practice within my field of prescribing. Non-compliance with this can result in a prescriber being removed from the Clinical Commissioning Group, NMP register, and subsequently being unable to prescribe. Agreement with mentor. Continuing professional development requirements should be identified at least annually during the nursing midwifery practitioner's appraisal. As my mentor is responsible for reviewing me as an NMP, I have agreed a timetable with her to meet and discuss competencies, prescribing, and continued professional development. This will be more frequently initially due to me being newly qualified non-medical prescriber. Key issues: continually adhering to guidance and frameworks such as the Royal Pharmaceutical Society, the National Institute for Health and Care Excellence and Medicines Prescribing Centre framework, the British National Formulary, and NICE guidance and peer group review networks locally with other prescribers to ensure and promote safe and effective prescribing. I will also be conducting regular audits, formula reviews at local and national levels to remain current in my prescribing practice. Participation in industry-related educational events, speaker meetings and further courses to upskill and continue learning in order to promote patient-client care without compromising safety. To facilitate easier access and increase patient-client choice to source the care, medicines and treatments they are looking for. My references were obtained from the European Journal of Neurology, the Journal of American Academy of Dermatology, the US Library of Medicine, Mechanisms of Botulinum Toxin Type A, the Informed Consent Nursing and Midwifery Code 2015, Nurse Education Today Journal, and Toxicon 2013. These are all documents on the final slide of this presentation alongside the web resources.